Budesonide inhaled corticosteroid in asthma and Crohn disease, low bioavailability therapeutic profile. Asthma affects is almost equal to 339 million people worldwide, and Crohn disease impacts is almost equal to 0.3% of adults in high-income nations, both conditions contributing to substantial healthcare costs. Budesonide's high topical potency combined with less than 10% systemic bioavailability after inhalation or oral controlled release delivery minimizes adrenal suppression while delivering anti-inflammatory effects. Diagnosis relies on objective lung function testing for asthma, greater than or equal to 12% and 200 ml FEV reversibility, and endoscopic plus histologic criteria for Crohn disease, greater than or equal to 5 mm ulcerations on ileocolonoscopy. First-line therapy uses budesonide 200 to 400 g bid via meter-dose inhaler for asthma and 9 mg once-daily oral granules for Crohn disease, with guideline-driven step-up strategies for refractory disease. Key points. Note: budesonide inhaled corticosteroid, ICS, has a systemic bioavailability of is almost equal to 5% after oral inhalation and is almost equal to 9% after oral controlled release granules, markedly lower than fluticasone, is almost equal to 1%. In asthma, budesonide 200 g twice daily, total 400 g, reduces severe exacerbations by 38%, GINA 2024, NNT equals 5. For moderate to severe asthma, budesonide/formoterol 160/4.5 g DPI bid achieves a 24-hour bronchodilation with a 30-day exacerbation reduction of 42% versus placebo. Oral budesonide 9 mg once daily for 8 weeks induces clinical remission in 45% of Crohn disease patients, ECCO 2023, NNT equals 2.2. The incidence of oral candidiasis with inhaled budesonide is 5% at 400 g bid, decreasing to 2% with spacer use. Budesonide suppresses serum cortisol by less than or equal to 10% after 12 weeks of therapy at less than or equal to 800 g/day, compared with greater than or equal to 30% suppression for high-dose fluticasone. Asthma Control Test, ACT, score improvement greater than or equal to 3 points occurs in 68% of patients receiving budesonide 200 g bid. In Crohn disease, fecal calprotectin falls below 150 g/g in 62% of responders after 8 weeks of budesonide 9 mg daily. Budesonide is pregnancy category B, US FDA, with no increase in major congenital malformations, RR equals 0.97, 95% CI 0.84 to 1.12. In patients greater than or equal to 65 years, dose reduction to 100 g bid maintains greater than or equal to 80% of the efficacy while having the risk of dysphonia, from 7% to 3%. Budesonide is contraindicated in active untreated tuberculosis, TB, due to risk of disseminated infection. Screening with IGRA is recommended before initiation. The SMART, single inhaler maintenance and reliever therapy, regimen of budesonide/formoterol reduces emergency department visits by 46% compared with fixed-dose budesonide alone, SMART Asthma Trial 2022. Overview and epidemiology. Budesonide is a synthetic glucocorticoid classified as an inhaled corticosteroid, ICS, for asthma and a locally acting oral corticosteroid for inflammatory bowel disease, IBD, principally Crohn disease. The International Classification of Diseases, 10th revision, ICD-10, codes are J45.9 for asthma, unspecified, and K50.0 for Crohn disease of the small intestine. Globally, asthma prevalence is almost equal to 4.5% of the population, is almost equal to 339 million individuals, with the highest rates in the Western Pacific, is almost equal to 7%, and the lowest in sub-Saharan Africa, is almost equal to 2.5%. In the United States, the prevalence is 8.3% among adults and 10.1% among children, CDC 2022. Crohn disease affects is almost equal to 0.3% of adults in North America and Europe, translating to is almost equal to 1.2 million individuals in the United States, CDC 2021. Age distribution for asthma peaks at 5 to 14 years. Incidence is almost equal to 12/100,000 person years. And again at 55 to 64 years, incidence is almost equal to 9/100,000 person years. Crohn disease incidence rises sharply after age 15, reaching a peak of is almost equal to 15/100,000 person years at age 30 to 35. Pathophysiology. Budesonide exerts its anti-inflammatory effects through high-affinity binding to the glucocorticoid receptor, GR. Kd is almost equal to 0.5 nanomolar, and subsequent transrepression of NF-kappa B and AP1 transcription factors. The molecule's high lipophilicity, log P is almost equal to 2.3, facilitates rapid uptake into airway epithelial cells, where it is converted to the active 6-beta-hydroxy metabolite, is almost equal to 15% of administered dose, with negligible systemic activity. In asthma, airway hyperresponsiveness is driven by eosinophilic inflammation, mast cell degranulation, and Th2 cytokines, IL-4, IL-5, IL-13. Budesonide suppresses IL-5 production by is almost equal to 70% in bronchoalveolar lavage, BAL, fluid after 4 weeks of therapy, Airways 3 Trial 2021. The drug also reduces airway smooth muscle remodeling by down-regulating matrix metalloproteinase 9, MMP9, expression by is almost equal to 45%, histologic analysis, 12 weeks. Clinical presentation. Asthma atypical presentations include isolated cough in is almost equal to 12% of elderly patients, greater than 65Y, and exercise-induced bronchospasm without baseline symptoms in is almost equal to 7% of adolescent athletes. In patients with comorbid obesity, dyspnea may be misattributed to deconditioning. Objective reversibility testing remains essential. Key points: dyspnea on exertion, present in 92% of patients. Wheezing, 85%. Cough, particularly nocturnal, 78%. Chest tightness, 63%. Diagnosis. 1. Step 1. Confirmation of variable airflow obstruction. 2. Step 2. Assessment of inflammation. Key points: spirometry demonstrating FEV/FVC less than 0.70 and greater than or equal to 12%, greater than or equal to 200 milliliters. Increase in FEV after 400 g albuterol. Sensitivity is almost equal to 84%. Fractional exhaled nitric oxide, FeNO, greater than or equal to 35 ppb supports eosinophilic phenotype. ppv is almost equal to 78%. Blood eosinophil count greater than or equal to 300 cells/L correlates with steroid responsiveness, or equals 2.3. Chest radiograph to rule out COPD, bronchiectasis, or cardiac disease. Specificity is almost equal to 95%. Management and treatment. Asthma exacerbation. Crohn disease flare. Key points: immediate high-flow oxygen to maintain SpO2 greater than or equal to 94%, target PO2 greater than or equal to 80 mm of mercury. Nebulized short-acting beta-2 agonist, SABA, albuterol 2.5 mg via nebulizer every 20 minutes for the first hour, total less than or equal to 10 mg. Intravenous magnesium sulfate 2g over 20 minutes if no improvement after 3 SABA doses. RR is almost equal to 0.68 for hospitalization. Systemic corticosteroid, methylprednisolone 125 mg for push, then 40 mg POQ6H, total 160 mg per day, for greater than or equal to 24H. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.